Good morning, everybody. Today we are arrived at our fourth appointment of this series of webinars. It is not working.
Now you should be able to change the slide.
No? Okay. Okay, thank you. So we started, we started the first appointment approaching the concept to guide the eruption of the teeth and to use this peculiar movement to use the guidance of occlusion like a therapy to approach the malocclusion and to transform a developing malocclusion in a normal occlusion. After we spoke about the opportunity of treatment, speaking about the open bite and deep bite, the vertical problems, and we will see today and in the next appointment that the vertical problem is really very important to be treated in early period. And other indication like early crowding, difficult eruption, tendency to class 2 and class 3 growth. But a transversal problem like cross bite and scissor bite and all the large topic of the bad habits. And it is not working very well. We have seen what we need not to treat, and it means that all the cases that in early period of the growth are just very extreme in their evident signs, it's better to approach in a different way. And after this, we were speaking about, oh, Dan, is it not working from my computer?
It should be. Let me check.
I don't know why.
Are you able to change the slide?
Oh, let me see. Okay, sorry for the audience, but after this, we were speaking about indication and contraindication, and we saw all the indication about early treatment, in particular way approaching early treatment with performant appliance, with appliances that are able to guide the eruption of the teeth. And we saw which kind of malocclusion can be treated in this way. Moreover, we saw that we can use different kind of morphology of appliances, and you can see the different colors of the boxes. That means different appliances that can use in a different way, in my experience, during the growth, so that to manage the bad habits, the primary dentition, and later the early mixed dentition and the late mixed dentition, and at the end the permanent dentition. But today I want to approach the vertical problem, and I want to speak about the deep bite. The next appointment will be about the open bite, so we can see how to manage two different kinds of two different templates of growth, so that we will be able to manage this problem. When we approach the deep bite, we need to know that the vertical alteration in the incisal area is really very important, not only because of the aesthetic correlation, but moreover because a altered value of the overbite and the overjet can create problems in the TMJ area. And this means that the function and morphology of the TMJ could be working not so well after the growth. So we need to manage these two parameters, overbite and overjet, in the anterior area of the mouth, and these two parameters are strictly connected each other. So when we have an increase of the value of overbite, we can see that we can arrive in a situation like in this slide, in which the border of the lower incisors touch the palatal gingiva. And if we look from the other side, we can see from the palatal point of view that this border is really touching very deep, and this can create in the future problems with upper incisor stability. And a lot of problems in this area that we can correct with brackets and with other strategies, sometimes with surgery combined to orthodontic approach. But if we manage this problem very early, we can treat the problem, reduce a lot the relapse, because we know that the deep bite is one of the kind of malocclusion that tends to relapse a lot. And the deep bite at the end is the expression of the dental position, of the incisor position, but often is an expression of a relationship between upper and lower arch. Because when we have a face that is growing in a deep bite structure, in which the face is short, we can see from the design of the arrows in this slide that we have a rotation of the mandible, a change of the structure of the mandible, a closure of the goniacal angle, with this typical aspect that is completely different from what we will see next time, because the growth and the structure of a skeletal open bite is going exactly in the different direction. But we have to remember always that these two different structures are strictly connected with functional problems, because often we are able to think that when we have an open bite, like in this slide, it is easy to understand that the tongue is not working so well. But imagine that when we have this kind of occlusion, we have problems with the function of the anterior muscles of the mouth, and the tongue is not working so well in any case. So when we want to increase the vertical dimension, one of the easier way to approach is to consent the eruption of the molars. But if we have a situation in which we want to correct an increased overjet and we overact the molars, often we can increase the value of the overjet because of a post-rotation of the mandible. On the contrary, if we want to put forward the lower arch, we need to reduce the vertical relationship. And this can create a problem, in particular way, if we have not clear in our mind which kind of deep bite we are treating. Because when we approach a deep bite, we can have to treat some skeletal factors like mandible rotation, reduced goniacal angle, and small mandible body, a modification of the eye of the ramus, a clockwise rotation of the bispinal plane, a vertical deficit of the maxilla. But not only skeletal problems. we often have to manage dental problems, like we can see in this slide. Inclination of the teeth, alteration of the dimension of the teeth, increased incisal angle, or some missing teeth. Moreover, we have several functional factors that can condition the dynamics of the tongue, but not only because it is not pushing in a correct way in the spot area, where we mean that the spot area is the palatal gingiva immediately posterior and up the crowns of the two central upper incisors. But we can have a problem, and this is really very important, with the lingual posture, because if the tongue is pushing in the lateral way and it is not pushing forward, we can obtain that there is a vertical control of the growth of the molars, creating a functional divide. And it's very common to see clinical situation like this, and very often doctors and parents are not so interested to treat this, because they say they don't see a real problem, even if the lower incisors are completely disappeared, are completely recovered from upper incisors. And our work is to be able to understand the direction of the growth, the way of growing, and manage this, so that to manage all the path between the early age and the late age, and when our patient will become a young adult. So the therapy could be divided in two sectors. The first one is functional, the correction of the posture of the tongue, and improving this with my functional therapy. We can use exercises, but in my experience, today the children were, because in the last 2 months everything changed, but normally they have no time to do exercises, and often they don't like really to do this. And from this point of view, we will see that the morphology of LM Activator is very interesting, just to give the correct information, not only for the working way of the tongue, but to give a correct information about the postural position of the tongue. And from the other side, we needed to manage and to correct the dental-alveolar sector and the bone, the upper and lower jaw relationship from vertical point of view. And it's easy to understand, it's easy to imagine that if we can work inside the dental-alveolar sector, it could be easier compared with the orthopedic correction. And I will show you in the next slides how it's possible to manage this way of growing using LM activators, in particular way using a specific model of the LM activators family. And at this point, if you have some questions about this first part, you can write on the chat and I can answer. Otherwise, I will go on with my presentation, and we will have a next step for the questions.
Yes, we have a couple of questions here.
Yes.
It is. There are 3 questions. First one is all about early class 3 treatment, or A3 treatment, or is LM Activator only one class 1 or class 2? I can repeat the question. So the question is that is LM Activator only for class 1 or class 2? And how about treatment of early class 3?
Okay, yes. It's a very interesting question because it opens a very wide area. But I want to transfer your questions because I think that today we need to be concentrated not on the sagittal relationship, but on the vertical relationship. So please pay attention about the vertical correction. And it is perhaps less important to in early treatment to look immediately at the sagittal relationship. I don't want to say that it is not important to understand if we are treating a class 1, a class 2, or a class 3 tendency of growth in particular way, because when we have to treat a class 3, the clinical signs of the class 3 are often very important, and they express itself very early, and changing completely the occlusal relationship can create a lot of secondary effects. I think that I can say that when we have a vertical problem, it's possible to manage this vertical problem considering the indication that we give in the previous webinar to approach the vertical problem with LM activators. But pay attention when we have a class 3, because if you have a real class 3 growth, it's better at the moment to treat using different approach. This approach is working very well in an easy way in the class 1 and class 2 and in pseudo class 3. I don't know if the answer is enough.
I think that was very good. Thank you. I have a couple of other questions here. One is that, is LM Activator suitable for treatment of deep bite, which is a result of bruxism?
If we are speaking about bruxism in young adults, it is not possible, it is not good. But if we are speaking about a sort of bruxism in early period of the growth, I think it can, because we have to consider what is the bruxism during early period of the growth. It's something of different if we compare with bruxism in adults. We have two different situations in young children. The first one is that physiological increase of the clenching between the arches appear during the period in which the teeth are changing. And so we have two different moments between 6 to 7, 8 years of age, and between 9:30, 10 to 11, in which this can happen in particular way during the night. But sometimes we have some children that are able to have a very important clenching during the day too. I think that the LM activator can be used in this case if we modify and the appliance. What this means, that we need to normally, I don't have a very strict appointment, but in these cases I see the children the child that I am treating every week. Why? Because when I use an appliance like this, I know that the morphology of the appliance, and in particular way the lateral wings of the appliance, can create an interference in the lateral movements. And if this happens, the masters will try to destroy the appliance. And because of the appliance is silicone made, it's easy to destroy it. So if appear a little cut on the border of the appliance, I immediately modify the appliance, putting away part of the border. but in the next slides I will show you how I normally do this. I think that it is important to be able to manage children with a sort of bruxism in the first weeks for
Now we cannot hear you. Dr. Pellegrino, I think you muted yourself. Okay, can you hear us now?
Hello?
Okay, now we can continue the presentation. I think we will take the rest of the questions at the end of the presentation.
Okay. Okay, so we want to treat something like this. The bite, in which we can see that there is a strict relationship between upper and lower arch, and the lower teeth disappear inside the upper arch. And we have to remember later this morphology and this relationship, because this will be able to give some more information. Okay, and up. And so when we want to treat this problem, we have this group of appliances, and I just show you that it's we have different colors for the box connected with the different morphology of the appliances. And this then, is it working no more? Because I am trying to change.
Now it should be working.
No. Okay. So we have different colors, and it's very interesting to see that we have that the yellow and the orange are are short and low or high models. Oh, I don't know what is happening. I am touching nothing. Okay. We have two different thickness and two different lengths. We have the yellow and the orange that are short, and the blue and green that are long. But the yellow and the blue are low model, and the orange and the green are high model. This means that we can connect different morphologies with different structure of the face, with different relationship between the upper and the lower arch. So we can see in a very simple way, because it is not really so simple, that the yellow appliance, the low appliance, is connected with a horizontal groove of the face. At the same time, the orange appliance, the high model, is connected with a vertical groove of the face. And we have the short and the long model that are different between them, because of the long model is constructed imaging that is possible to control the position of the second molars too. And we know that the second molars will erupt after all other permanent teeth in the anterior part of the arch are erupted. And so if we start a treatment with an orange appliance, we need to complete with the green one. And when we start with a yellow appliance, we need to complete very often with the green, with the blue one. And if we look what we can find from on the market, we have different size with two different models of activators: LM Activator 1, the old series, and LM Activator 2, the new series. And in the old series, we can see a wider number of numbers, and moreover, we can see that in the LM Activator 2, we have the reinforced model. We have an appliance that is made not only in silicon, but have another part inside in the frontal area, and we will see that this is very useful when we start our treatment after the rupture of the upper and lower incisors. But the two models, LM Activator 2 narrow and LM Activator, are very similar in morphology. And just to give a look back about how LM Activator are made, we can see that are like a monoblock. The upper and the lower arch are connected together around an occlusal plane, and there are vestibular and lingual sheaths that protect the teeth during eruption. And the upper view, in the upper view, we can see that we have the position, the slots for incisors, for canines, and for the first premolars. After we have a completely flat area, and this area is very important to manage all the posterior sector of the mouth. All the appliances are marked in some way. We can see that in the LM Activator 2 series, we can see that in this part of the appliance, we can read the model of the appliance. It's easier to see here. In the LM Activator 1 series, we have the size of the appliance and the model. And on the contrary, in the LM Activator 2, we have that the size of the appliance is marked in the frontal area. So we have all the information we need to identify immediately the appliance. This is useful from a clinical point of view, because when I am working near the chair, I can test an appliance inside the mouth directly, and if it is not correct, I can put it in the autoclave and to have the appliance ready again to be used, because we can put the appliance a lot of times in sterilization way, so that we have no change in the physical and chemical properties. But the main characteristic of these appliances is in the posterior area, because we have a low model and a high model. And between this difference is, using this difference, we can manage the vertical problems inside the mouth. It's easier to see in this slide that the low models are very thin in this area. On the contrary, the high models have a different thickness in this area. So this that the molar in this area are much more controlled, and we will see in which way. So when we want to approach and to treat a deep bite, we will use the low model. Using the low model, we have that in the lateral sector, there is no contact between the teeth. On the contrary, we will have a full contact in the anterior part. So when we put the appliance inside the mouth, all the anterior teeth will be vertical controlled. On the contrary, in this part of the appliance, the lateral sectors will be able to overlap, and this will happen during the night. So this means that in this case, we can use the yellow and the blue appliance. And when we work using LM Activator during this period of the growth, we will manage consenting the eruption of the molars so that to increase the vertical dimension. And this means that when I approach the clinical problem in early age, and we are here about 6 years of age, it's possible to approach this problem managing it during the night, because it's clear that we have a class 1 relationship. The early mixed dentition is period is starting, and we can use an appliance that is able to guide the eruption of the teeth. Otherwise, I can wait and treat later with a multi-bruxism therapy or with a functional therapy. At this point, I will choose the size of the appliance, and for this I can use a tool in which I can read the size of the appliance that I can it's suggested to use in that mouth. And using the appliance just during the night, we can obtain this kind of correction. And if you remember, the lower incisors were completely locked between the upper incisors. And if we increase the size of the appliance during this period in which the incisors are erupting, we can manage the crowding, so to avoid the crowding in early mixed dentition. But we can treat late too. If we start about 9 years of age, like in this case, in which we have a serious deep bite too, yes, I can use a utility arch or a Barston arch to intrude incisors. But if I need, and if it's correct from the diagnostic point of view, I can increase the vertical dimension. I can consent to the eruption of the molars, and normally I design on a table like this the direction of the movement that I want to obtain. So I know that using LM activators, and in this case it will be a reinforced one, I want to avoid the overruption of the incisors, but I will not be able to have an active intrusion on incisors, and at the same time I will consent on overruption of the molars. And in this way I can manage the anterior and the lateral relationship at the same time, using the concept that we can see in the lateral arrows. And it is exactly this, the way in which LM Activator's law is working. But during the treatment, it can appear that the appliance is broken, like in this area. And I instruct the parents that it is very important that they call me when they see some sign on the appliance. And in this way, when I have this situation, I want to cut away some silicone using some scissors, so to modify the morphology of the appliance in that area. And this is the clinical effect, working again only during the night with this appliance night time. But I just want to come back on some slides, because I just wanted to tell you something more. Because if you look at this area, you can see that this is cut too. Because when you choose the appliance, you have not only to see the size using the ortho sides, but you have to check that the silicone in the posterior part of the appliance is able not to push on the mucosa, because if we have a pushing pressure on the posterior mucosa, the appliance will be put forward of the mouth. In particular way, if we use the appliance only during the night, as I prefer. So in case like this, I prefer to use the reinforced appliance. And again, the golden age is about 6 years of age, when the first lower incisor is appearing inside the mouth. In this period, we can change very quickly, working only during the night, and we need the time of the eruption of the incisors. But don't forget that we are looking here, but we are working in particular way in the vertical relationship of the molars. In this clinical application, we use the appliance for this period, and in this period, I use just 2 yellow appliances. I used 2 because I needed to increase the size of the appliance, so to reduce the crowding inside the mouth. But I just want to take home message, and this is the vertical control. We can have a vertical control if we start very early, and only if we start very early we can reduce the relapse of the vertical increase in the correction of the deep bite, because we know that if we overwrap the molars later during the growth, we can find some relapse of this movement because of the power of the masticatory muscles. And so we have we have a cure. In the middle we have a normal situation, but we have to imagine that along this Gaussian curve we have that in the middle there is the normal, but we have going forward the 2 different ends. From one side we have the deep relationship, and from the other the open bite relationship. And near normal relationship we have dental deep bite, and in some extreme cases we have a skeletal deep bite. And these different occlusions are connected with different structure of the face. And this is very important to remember, because if in this situation, I can have a wonderful result with a good stability, but in this situation, my treatment needs to be checked for a long time. Otherwise, it's possible to have a relapse because of the power of the muscles of the structure of the face. And connected to this concept, I just want to share with you 2 different concepts. One expressed from Tiziano Baccetti about the treatment of class 2, and about the concept of the goniacal angle. Because if the goniacal angle is increased in some way, this means that change the condyle inclination. And if the condyle inclination change, this means that we will have different growth of the mandible. And in particular way, in some class 2, we can increase the mandible growth. But connected to this, I just want to remember the point of view of Demar, that is a Swiss orthodontist, and he says that if you have an horizontal growth pattern in which the deep bite is very expressed, some opening of the goniacal angle might be even favorable, but the relapse is near the angle, is behind the angle, because we can have not stability of the treatment, but this concept is really connected with the period of the growth in which we have the treatment, because this is really very important, and it is really true if we treat normally during the late mixed dentition and during early permanent dentition. But this concept is completely different if we approach in early mixed dentition. So the golden age to treat deep bite is between 6 to 8 years of age, in the period in which incisors and the first molars, permanent molars, are erupting. And we can use LM activators to guide the eruption of the teeth in the anterior posterior part of the mouth, so to guide this vertical relationship and to manage the occlusal plane. And in this way, we will use the power of the dental eruption. And again, if we are not able to use in a correct way LM activators or all the other appliances like this, we will have the problem of the dental compensation. And we need to manage the dental compensation so to avoid this kind of problem. So in the last webinar, there was some questions about the difference between MyoBrace and LM Activator. And I just inserted some few slides just to compare these two appliances, because they are different. If we start from the first line of appliances, we can compare the MyoBrace for units for family dentition that are very similar to trainers. They use the same concept, but they are made in different materials and they have a different morphologies. If we analyze going on with the growth, we have that the mixed dentition, or we have the MyoBrace for kids that is connected with the use, is in the same period of the use of the yellow and orange, and in particular way, if I use the yellow, the reinforced yellow, the reinforced low. But you have to remember that the difference between these two appliances is very important, because we have that here we have a flat plane, and here we have a different plane between the anterior part that is higher than the posterior part. And for teens is exactly the same concept. When we arrive in the adults, we can use the yellow and the green compared with this model of MyoBrace for adults. But you have to remember that in my experience, it is not so frequent to use directly the long model, the blue and the green. Normally, I use them after after treatment with the LM Activator low or high short. So after the yellow or after the orange. And at this point, if you have some, is there some other questions, I can answer to you.
Yes, there are some questions on the line, and maybe some of them were already answered, I think, during your presentation, but I will still read them all. So first, there is a question about the wide model. What is the wide model compared to narrow? And I can actually answer to that shortly myself. So the wide model is actually referring to the arch width. So it's a wider, for children with a wider arch. And if I explain that it's actually targeted for the Asian and more specifically for the Japanese market, so then you understand that it's like a different kind of facial structure that this is more, let's say, suitable for. So it is there. Of course, there can be some children also in Europe who can benefit from these appliances, but they are mainly used in Asia. So the
Yes,
narrow model would be the correct one for you in Europe.
Yes, I use only the narrow model or the activator of the previous series. I don't use my daily work the wide model.
Then there is a question: in what age do you usually start to use LM Activator?
Oh, normally I start as soon as I see a vertical problem, even if normally the general law is before 6, before the eruption of the permanent teeth. I prefer in general to use the trainer, even if I have a serious open bite in primary dentition. Sometimes I prefer to use, as we will see next appointment, the high model, the orange one. After the eruption of the first permanent incisors, I always use LM Activator.
Then there is a question about actually what you referred to already. So maybe you answered this, but I will read the question. Very often with the deep bite, the incisors bite through the activator in the frontal area. What do you do when this happens? Can you?
Sorry, the audio went away. Can you repeat?
Yes, I can repeat. It was a question about that some patients bite through the activator in the frontal area, and what do you do when this happens?
Sometimes the deep bite.
The incisors bite through the activator, so it gets broken.
Oh.
You already referred to that in the front area.
Yes. Okay. Sometimes it happens. Even if I have to say to you that in the past it was a situation that happened very often. Actually, it is not so common. Why? Because I think that if you start when the incisors are just erupted, it can happen easily. This is the reason for which I prefer to use the reinforced one. If you start during the eruption of the incisors, it's not so common. But the problem that of the cut in the anterior part is connected with an overdevelopment of the occlusal forces. Is connected with the muscles that are clenching a lot on the appliance, and this is not the correct way of working. But before to cut the appliance in the anterior part, and we will see in the next appointment that in the orange the cut is in the posterior part. Before that this occlusal cut appear, if you pay attention, you will see that some cuts on the border of the appliance will appear before. So if you reduce the eye of the lateral shadows of the appliances, the vestibular borders, upper or low of the appliance, in the area in which very little cut can appear before, you can reduce a lot the number of broken appliances in the incisors area. But once it is broken, I try to modify, to repair, and it needs time, and it is working not so well. So I prefer to change the appliance.
Okay, thank you for the answer. Then there is a question about what about combining LM Activator with space control appliance like lingual arch and others?
Yes, very interesting. I use daily this kind of combination. Lingual arch in the lower arch, and transpalatal bar in the upper arch. Sometimes even quadratics in the upper arch. Why? because if you look at the morphology of the appliance, you can see that if you are using a fixed appliances on bends, on molars, or last primary molars or first primary molars, you just need to cut a little some part of the silicone to fit well the appliance inside the mouth. So I think that this combination of appliances can give us a lot of opportunities to manage the vertical relationship, but at the same time not avoiding in particular way in the lateral sectors of space that is very important for the future of the developing of the arches.
Okay, I will see. There is one specific question to me, which I will address. Thank you very much. Outside of the webinar. So thank you, Arina. I will come back to you.
Okay.
Then there is a question actually in Italian, and I think it's about that the role of the tongue in deep bite is not very clear for this person who is asking. It's in Italian. It says that il ruolo della lingua nella patogenesi del deep bite non mi è chiaro.
Okay, okay. It's not so easy to explain, but the central point is normally to give a normal development of the upper lower arch. The tongue needs to put the point, its point on the spot area, and then during the working way to press in the palate and then to push in the lateral sectors to put the saliva back. This is active movement, but we have a static movement, static position, a postural position of the tongue. And between these two kind of relation between the tongue and the teeth, normally we see that in the open bite, the tongue tends to be in different way put it forward to increase, to sustain, or to create the deep bite, the open bite. But what happened in the deep bite? In the deep bite, we have exactly the opposite. The tongue is pushing in active working way and in postural position in the lateral sectors. And it is just like a pressure that avoid the eruption of the molars, so not to consent the increase of the vertical dimension. If you want to test, you can use some fluoresceina, that is a colored past, so to substance, a colored substance to put on the tongue and to see the working way and where the tongue is pushing on.
Okay, that was actually all the questions. We have many. Thank you for the webinar here on the line. So we will.
Yes.
I think we can go on, and actually
yes.
We will only present then the next webinar.
Yes, the next webinar, it will be in June, and thank you to everybody to spend your time today with us. And the next appointment will be the last one of this series, and it will be about the open bite, how to manage and how to treat the open bite using LM Activator. Thank you for your time, for your interest, and to see you next month.